Assalamu alaikum, with you, Dr. Toha Sayed. Good morning and good evening, wherever you are. Today is our session regarding talking about checking of anesthesia machine. So let's go to start because this is very important to be prepared from the beginning of the day for everything, starting with the basic monitoring till checking the anesthesia machine itself. So here are our main steps, which are basic standard monitoring, the medications, airway devices, backup ventilation equipment, and anesthesia machine itself. So the anesthesia machine, it's checking starting from the beginning at the first minute in the operation theater with checking of standard monitoring. So let's talk about the standard for basic anesthetics monitoring, which is done or are done by ASA, American Society of Anesthesiologists. The most important and the standard number one is the qualified anesthesia personnel. So the whatever whoever this one, the resident, the assistant lecturer, specialist, consultant, anesthesia technician, he should be qualified, should be present in the room all over the time of the operation during conduction of anesthesia, whichever method of anesthesia you are doing to the patient, general anesthesia, regional anesthesia, or monitor anesthesia care, which is abbreviated as MEC, or conscious sedation. This is standard number one. And the most important one in the anesthesia on the operating theater is the anesthesiologist himself. And this is an important question for MCQ and oral exam. After that, everything is coming later. Which are the standards during all anesthetics? During the conduction of anesthesia, patient uh, should be continuously evaluated for oxygenation, which is to provide oxygen for the patient, ventilation, which is to eliminate CO2 and avoid retention of carbon dioxide, circulation, which detect heart rate and pressure, blood pressure for the patient, and temperature, which when you are suspecting that the patient is having a violent and aggravated body temperature changes. So adequate ventilation of the patient during all anesthetic should be ensured. And to know the difference between ventilation and oxygenation at this point, we can talk about the operation of laryngeal tumor, which is removed by a laser. At this time, we remove the endotracheal tube, and during the working of the surgeon, if he is not going to conduct laser at that time, you can provide an oxygen line to the patient, which will diffuse passively for oxygenation of the patient. But after 2 or 3 minutes, you go to ask the surgeon, please let me ventilate the patient to eliminate some of CO2 retention happened during last period. So oxygenation means giving the oxygen to the patient in this operation. So you will find this mostly in the microlaryngeal operations. And if at the time we are not using laser, we are not using laser, we prevent the patient with oxygenation. If we are using the laser, we stop oxygenation to avoid burn. Okay? Okay, then provide adequacy of the patient circulation function during all anesthetics should be ensured. And as we said, the temperature monitoring when there is a clinically significant changes in body temperature, if it's intended, like in neurosurgery operations, anticipated, like in long operations for exploration, or suspected if we are going to have a violent change in body temperature of this patient during operation, and large fluid shift during this operation. So again, we have two standards. First standard is qualified anesthesia personnel shall present in the room throughout the conduction of anesthesia. Any type of anesthesia, general, regional, which means spinal nerve blocks, and make anesthesia care, which means conscious sedation. And the other standards, which during all anesthetics, to maintain the patient oxygenation, ventilation, and circulation temperature to be continually evaluated. Oxygenation means oxygen concentration of the inspired gas, observation of the skin, patient skin and membrane color to maintain their color is still pink, not getting bluish, and pulse oximeter. Ventilation, observation of the patient and reservoir bag if the patient is on manual mode, or ventilation circuit disconnection alarm if the patient on control mode, and auscultation of breath sounds to ensure that the tube is inside and inside the airway and not shifted to one of the lungs, not to make one lung or single lung ventilation. Okay, and continuous end-tidal carbon dioxide measurement by capnography, circulation, continuous ECG, display, heart rate and blood pressure measured at least every 5 minutes. This is standard for every operation to have at least heart rate, blood pressure recorded every 5 minutes. Evaluation of circulation by auscultation of heart sound, palpation of pulse to measure the pulse at peripheries or like radial artery, or to feel the pulse at central arteries like femoral and carotid arteries. Pulse plethysmography. This is the drawing of pulse oximeter on the monitor. Pulse oximeter, intra-arterial pressure tracking, and temperature, as we said, when there is significant change anticipated, intended, or suspected. And here we have three questions, MCQ questions, common coming in the exam. The first question: to help encourage universal quality and safety practices, the ASA has adopted and mandates the use of all of the following monitoring during general anesthesia, except oxygen analyzer. This is used for oxygenation, so it's correct. Capnography, this is to monitor carbon dioxide, so it's correct. Continuous visual display of ECG, this is for circulation, it's correct. A peripheral nerve stimulator, it's not a mandatory device to have a peripheral nerve stimulator in an OT, so this is the wrong question. But it's recommended to have this device if you are giving muscle relaxant to know when to start reversing of this muscle relaxant. So it's not mandatory device, but it's a recommended device. Okay, current ASA standards require that during anesthesia, systemic blood pressure and heart rate should be evaluated at least every 5 minutes. And some sources say during OBS and gynae every 3 minutes. But the correct answer, which should come to our, which we should answer in our exam, is 5 minutes. Answer number B. According to American Society of Anesthesiologists, temperature monitoring is always required? No, when there is a significant change in temperature. Never required but recommended? No, it's mandatory device. Required for all general anesthetics, however, not required for sedation? No, when there is a change anticipated, intended, or suspected. Up to the discretion of discretion of the anesthesia provider. This is the correct answer when you are having a suspicion regarding a significant temperature change. This is about your own experience. Okay, so we have finished the standards or basic monitoring. Going to the next, the medications. Main types used in general anesthesia and regional anesthesia. Induction medications, hypnotics, analgesics, muscle relaxant and the reverse. For example, if or their antagonist, like here in others, the antagonist, if you have the muscle relaxant rocmoronium, which is trade name is moron, its reverse is sogmadex, which its trade name is prodion. So if you have ismoron, you should have the pradion in order to reverse it easily, or you should have the neostigmine and atropine for reversal of other muscle relaxants like atracurium and cis-atracurium, drugs of amnesia like dormicum, midazolam, antiemetics, ondansetron, and dexamethasone, and other medication modulate sympathetic and parasympathetic response like ephedrine, phenylephrine, and atropine. Third step, to be anticipating for every patient from the conventional to additional airway devices. Here we see all the airway devices available, which either oral airway, mask, Macintosh, Miller laryngoscope, Macintosh laryngoscope, tube, intratracheal tube. For every patient, we should have two sizes of tube, to one of the same size or expected size and one of lower size. Classic laryngeal mask or second generation laryngeal mask, video laryngoscopy, CMAC, flexible fiber optic bronchoscopy, and additional and these devices for advanced airway if you are suspecting to have this patient with difficult intubation algorithm for Ganzuri score. And finally, you should have these additionals like the tongue depressor, the bite block, bronchodilator, and nasopharyngeal airway if they are needed at any time for the patient. We finished checking airway devices, so going to next step, checking backup ventilation, ambo bag with self-inflating bag, and others like suction apparatus and auxiliary oxygen cylinder, and both of them should be working. And then fifth step, going to check anesthesia machine itself. So starting to check anesthesia machine itself, starting from the first step with the electric plug, checking the source of electricity to check for the AC electric indicator, and backup battery indicator should be checked. You will connect the device and check that both of them are working. And if you remove the electric plug from the socket, should be battery indicator only working, and should give you an average estimation of battery life, which almost 60 to 90 minutes as an average for most of the devices. After checking source of electricity, going to check gas supply. As we know previously, we have two types of gas supply to anesthesia machine, which are pipeline and oxygen cylinder, which are maintained at the back of anesthesia machine. I should I should verify that at least of the backup oxygen cylinders at the back of the machine having pressure of 1000 psi or more. And after checking that, you should close this cylinder. And to check central pipeline supply, that the pressure inside this pipeline is more than 50 psi. Okay, and we should know that in case of having central pipeline supply down and you are going to make the patient on the ventilation for these cylinders, it's better to go for manual ventilation using bag to avoid quick depletion of oxygen inside these cylinders. Third step, checking for flow meters, and we should know that they should be at the base for 0, but some devices allow minimum flow only for 250 milliliter per minute for oxygen as it's at its base, or as a 0 because in case of emergency some anesthetists forget to operate or switch on oxygen knob or rotate the oxygen knob. So to avoid hypoxia for this patient, it gives minimum of 250 milliliter per minute. Okay, and we should check that the flow tubes are undamaged, floats move smoothly, not cracking with the tube, and at low oxygen pressure other gases stop. Okay, if you disconnected the oxygen pipeline from the wall or from any from anesthesia machine, you will hear oxygen failure alarm and sodium and nitrous oxide float will drop. Why it is dropped? Because of this proportion system. Okay, and as we revised in last session, that fail-safe valve will not allow sodium uh, nitrous oxide to go without oxygen. Okay. Finally, the last point is proportion system 3 to 1 between nitrous oxide and oxygen should be working well in order to avoid hypoxic mixture. Number 4 is the vaporizers. I should make sure that the full and fill ports are closed and only one vaporizer is working at the same time, working at a time, not both of them are working, to avoid mixture of different gases and their side effects. And at this point, we are talking, as I told you previously, low pressure system. So for low pressure system is starting from the flow meter, vaporizer till the patient, where the pressure for oxygen is 14 psi and for nitrous 26 psi. Before this flow meters, the pressure is around 45 to 50 psi. Okay, so how to make the leak test for this low pressure system? We have two leak tests: positive pressure, which is used for old machines, and negative pressure leak test, which is used for the new and modern machines. In positive pressure leak test, I I close the ABL valve with 30 and flushing oxygen from flush valve, and to maintain the pressure inside this circuit at 30 centimeter water. Okay, if this pressure isn't maintained for 10 seconds, we have a leak, which could be at vaporizer area or at flow meter. In modern devices, we have something called check valve, which is a unidirectional valve and not allow this pressure to come back to the vaporizers and flow meter. Why we invented this valve? As we know in vaporizers session, that this valve is preventing the pumping effect when the patient having high pressure inside his chest like coughing. So it prevent bumping effect from the vaporizer. Okay, so this check valve could make a misleading that there is no leak and there's actual leak here in these areas, in this vulnerable area, or even dangerous that we are not providing a good oxygenation for the patient. For this reason, we have negative pressure leak test, which we are using this suction bulb, and we put here at common fresh gas outlet. Okay, this suction bulb, I make it using negative pressure, okay, and this flow meter and vaporizers are closed. If it remain collapsed, so I am sure that there is no leak because it's still negative pressure and it doesn't get any air inside. Okay, if it get inflated at any time, there is a leak at the flow meter, so this flow meter is faulty. Okay, if vaporizers are closed or switched off and it get inflated, so the problem in the flow meter. If all are closed and it's still collapsed, so there is no leak, you will test each vaporizer alone. Open this vaporizer, switch on, turn off, turn on, turn off, turn on, turn off to check if this suction bulb get inflated or not. For the for the, to check for negative pressure leak test. If there is no leak, it will remain collapsed and we can proceed to the next step, which is the connection system or the breathing system. At first, to check the breathing circuit, it's not having any cracks, not damaged, and CO2 absorber not having discoloration, and calibrate oxygen sensor. This is the trigger anesthesia machine oxygen sensor. At first, to start calibration, we put it in the air and tell the device that calibrate this as a 21%. Okay, and it will give the calibration, and we will set the alarm at 30% and say calibrate it as this 30%. We told it before that it's 21%, so alarm will make the sound and noise. After that, we will put this sensor to its place and open 100% oxygen and say calibrate it to 100% oxygen. And like this, we have calibrated the oxygen sensor for anesthesia machine. To check the function of unidirectional valve, we know that we have two unidirectional valve for inspiratory and expiratory limb. We remove the white piece and make inspiration, make a flow in the inspiratory valve, and we are switching off fresh gas inlet and closing the expiratory limb. If this bag or this reservoir get inflated, so this valve is incompetent. Okay, if it not get inflated, so this valve is A1 and it's working. To check for expiratory valve, you put the bag in the expiratory limb and close the inspiratory limb and fresh gas flow, and you blow in the single line or the single tube which was bag connected before. If this bag is inflated, it is incompetent, and if this bag remains same size, so this expiratory valve is competent. Okay, checking for oxygen flush positive pressure leak test. We make sure that all gases are off and switch the bag and switch the device to bag, not the ventilator mode. Close ABL valve for 30 centimeter water. Okay, includes the Y piece device with a finger or with this area designated area on the anesthesia machine and flush the inflate the bag or flush oxygen to centimeter water if the circuit holds the pressure for more than 10 seconds, so there is no leak. If the pressure demolished or decreased before 10 seconds, there is a leak and it should try to find it. Number 6, scavenging system to ensure that the proper connections and adjust the vacuum and check for positive and negative pressure relief valve. How to check for negative pressure relief valve? It's easy. We will start the scavenging system, switching off all vaporizers and follow meter. Should be, if it's negative, it will not go from zero. But if the negative relief valve is not working, you will find that circuit become having a negative pressure inside. And for positive pressure, we will flushing oxygen to the circuit. If the circuit maintained zero pressure, so the relief valve is working, positive pressure relief valve is working. If the pressure inside the circuit become high or increased, so positive relief valve is not working. And finally, which all of us is doing it as if he already done the whole previous step of anesthesia machine checking and consider this as the sole checking method for the machine, is the ventilation system, and which we all doing to connecting the bag with the ventilator and checking for the controlled and manual ventilation. This is the last step, not the whole step for checking anesthesia machine. And at the end of this checking, the final status of machine, zero flow for all flow meters except oxygen 3 liter per minute, all vaporizers off, back ventilator switch at back mode, ABL valve open, not closed, attach face mask to eyepiece to be ready for ventilation, adequate suction, breathing system and monitors ready for any patients. And here, the end of our session. I will put a video for anesthesia machine checking in the description below. Please check it. It is the same device of GE device used in our hospital Qasr Aini Medical School Hospital. It's very informative. Please check the video in the links in the description below. And thank you for your attention today. Have a good night or have a good day. Bye.